So Diane, I want to start today by sharing my title of my notes for our interview, our time together today, which is Interview with My Love, Diane Meier. And also we were teasing, but really not teasing, that I hope we get to do this every Sunday, forever. And we can call it, instead of Tuesdays with Maury, we were joking, it can be Sundays with Meier.
Sounds lovely.
So we get to have our Sunday together, which is such a treat for me. So thank you. Anyone not familiar, just quickly by ways of an intro, with how much of a freaking rock star you are, should watch our interview, I think, from last week, because we started with me making you uncomfortable by listing out all of your accolades. And instead of doing that again, I'm just going to share, you're the director of the Center to Advance Palliative Care, which is referred to all of us as CAPC. You're a palliative care doctor, a professor, an entrepreneur, a culture changer. And as we saw last week, I would say a therapist of sorts, and how you care not just for families and individuals across the country, but for us. We got off the phone with you and described it as transformative, I think, for our team, literally transformative. So you are deservedly famous across the world for your work in palliative care, a profession that you helped invent, and an expertise you are helping to make a household term. You're also in the middle of all of it right now, like never before. So I wanted to start by asking you, how are you now, 1 week later?
It's the new normal. It's really interesting how resilient humans are and how we can adjust to profound disruption and dislocation. I would say that a week ago, I was more kind of looking, what's the right direction? Where should I be putting my time? Where should I be focusing my energy? It was a sort of an acquired ADD state of constantly scanning the environment for signals and figuring out what action was necessary. And just a week later, the organization I work for, the Mount Sinai Health System, the city I live in, the state I live in, has gotten this down to not a science at all, but the things that were started have been put into place in ways that are kind of stunning because they happen so quickly. Our lobby at our hospital is an intensive care unit. Our operating rooms are ICU beds. We have a tent across the street in Central Park run by Samaritan's Purse that is taking Mount Sinai Health System patients. We have turned our palliative care unit into a COVID-19 unit. All of this occurred with a speed unprecedented in my experience in a large organization, and they're all up and running. So it feels as if we've settled at a new place of stability in that we know what we need to do and we're doing it.
Yeah. So you and I laughed at the end of our time together last week because, as a demonstration of my super sucky interviewing skills, I didn't ask you until the end to explain what palliative care is. So I want to ask you that question, but I want to ask it of you in a very specific way. If I had stopped you on the street 2 months ago and said, what is palliative care? How would you have answered it then?
So interesting, because we have buttons at the Center to Advance Palliative Care that say on them, ask me about palliative care, to try to get anyone to ask exactly the question you just asked, because most people have no idea, either have never heard of it or have no idea what it is. And palliative, the reason it's understandable, it's a very new field. It didn't really start till about 10 years ago. And it is now a new medical and nursing subspecialty, just like cardiology or nephrology or pulmonary medicine. But this specialty is focused on the whole person and maximizing quality of life during a serious illness. Now, that serious illness could be something we hope to cure you from. It could be something that is chronic that you will live with, hopefully for decades. Or it could be an illness that's progressive, like widespread cancer, for example. So it doesn't matter what the future holds. We're here to help the patient and family in the here and now, to maximize quality of life, reduce symptoms and stress, and make sure that patients and their loved ones have the information they need in order to make the best decisions for themselves.
So, and I know a key part of it is how collaboratively you work with the team, with the existing clinical care team, and also with the family, which we would consider part of the team. How would your answer to what is palliative care change today? Would it change, and how might it be, even more intense, even more important at this particular moment in time?
That's a great question, because unlike at any point in my career, which spans many decades now, the recognition of the essential nature of palliative care is unprecedented. And what I would say is that our colleagues who often thought of it as nice to have, not have to have, as something someone or some team they could call in if they ran into difficult to manage pain, or they had a difficult family that wasn't hearing what they were saying. We are now perceived as essential in the same way that air is essential, in the same way that nurses are essential. We're an essential element of healthcare delivery. And that did not become glaringly obvious to everyone until we were hit by this pandemic.
You shared a little bit with me this week about this 24/7 communication line. Can you talk about that a little bit?
So prior to the pandemic, the Mount Sinai Health System and other health systems around the country had some level of palliative care team or capacity. Most of them were underfunded, understaffed, under-resourced. And what happened with this pandemic is that virtually every patient rolling in, no matter what their stage of the COVID-19 is, needs what palliative care has to offer. And the two main components. One is expert symptom management. A lot of these patients are quite short of breath, and help in reducing that very frightening feeling. And then on the other hand, communication skills. We as humans are not born with excellent communication skills, and the same is true for physicians and nurses. And the urgent need for skilled communication, particularly with the distraught families of patients who are not allowed to come into the hospital, cannot be at the bedside as they always have been in the past. Know that they are giving their precious loved one into the hands of a bunch of overwhelmed, overworked, exhausted healthcare teams. The suffering is incalculable. And what palliative care teams do is create a bridge that connects families and other loved ones in the community, not only to the doctors and nurses taking care of them in the hospital, but also to the patient themselves. And that is such a profound help at a time like this.
So, I mean, it's the most essential help. That bridge has to happen. How can a family member ask for that?
Right. So I wish I could say that it's universally available with equally high quality all across the country. And I hope that one of the outcomes of the COVID-19 pandemic will be the recognition that it must be universally available with equally high quality across the country. Unfortunately, that is not the case. What we do have, though, is a public-facing palliative care directory on a website called getpalliativecare, all one word, .org. And on that website is a program directory. You can type in your zip code, your city, and there will be a drop-down menu of all of the palliative care programs in your community or near you with phone numbers. And that way, you as a family member or as a future patient, or a hopefully not patient, but planning patient, can look up what the resources are in your community and reach out and understand what they are doing during this pandemic that will help people like you.
It was beautiful. You talk about palliative care capability as a scarce resource and how organizations need to manage it, therefore, right now, like a scarce resource. And I can't wait till it's not a scarce resource anymore, but it certainly is right now. And to your point, the needs for symptom management and communication expertise are higher than they've ever been. And it's so high that the teams that are on the ground can't meet it. So you have a large number of people, you explain, taking turns covering the palliative care consultation hotline, which you've never needed before. How is that working? Explain how that works.
So it's so simple. It's just a cell phone number, and that cell phone number is answered by a rotating group of, right now, medical students who are volunteering. And those medical students have a list of faculty attending physicians who are on call during any different 8-hour period. And they will patch the call through to the first person on the list, and that person will get a text and can respond, no, I'm on another call now, or no, I can't take it. Then they go to the next person and the next person. There are 4 or 5 people at any given time covering the line so that no call goes through to voicemail.
Give me an example of what one of those calls would be.
So I've had the privilege of serving on the hotline for the last little while. And what happens is, first I speak to the doctor at the bedside, often an intern or a resident, and they tell me a little bit about the patient and what their situation is. And I ask how the patient looks, because I know the family member is going to want to know, do they look comfortable? Are they resting comfortably? Can they communicate? How are they now compared to how they were a day ago or 12 hours ago? Because this is what the family needs to know. And then I ask the intern or the resident exactly what they are doing to support the patient now. What kind of oxygen support, what kind of medication support, how are their vital signs? And then I ask them what they need to know from the family. What are the questions they would ask if the family were at the bedside? And with that information, I then pick up the phone and call the family, and often wait for them to try to get everyone on the same line. So the other day I spoke to 3 adult children of a 72-year-old man who had come in from a nursing home, and waited while they all got on the line and introduced myself and asked them to tell me about their dad and what sort of person he was. And it was quite remarkable to hear about him as a human being, and how much they loved him and what a remarkable person he was. And then I asked them for their questions about what was going on now, and they asked me exactly what I knew they would. How does he look? Does he seem comfortable? Is he upset? How's his oxygen level? How are his vital signs? And then we got down to, what did he say to you when he was well about what he might want in the future if he got very, very sick? And he's not very, very sick to that point now, but we need to know what to do should that occur, because he's in a higher than average risk age group, because he's over 50, really. And they were very clear that he had said to them multiple times that he did not want a tube shoved down his lungs or resuscitation should he be near death, that he just wanted to be comfortable and peaceful. But that didn't mean he didn't want his life prolonged. So it was a very nuanced conversation. They wanted us to do everything we would normally do for a patient with COVID-19, short of basically cardiac resuscitation. So that if he were to get to the point of being near death, then they would want us to focus entirely on ensuring that he does not suffer. But prior to that, they believed he wanted, and they wanted everything medically reasonable done to support him and prolong his life. And that's exactly what the team needed to know at the hospital, because they knew that the family had said they did not want cardiopulmonary resuscitation, CPR, but that's just if your heart stops, right? What about everything before that? Well, before that, they wanted him to have every possible chance. And that was very important to get clear and to document. And we were on the phone for almost 45 minutes. And then we hung up, and I called the intern back at the other end and told her that. And that was critically important information. So now, actually he already was, but now we are continuing the sort of standard cocktail of treatments that we use: anticoagulation, antimalarials, antibiotics, antivirals, that everyone else in the hospital is getting. He's getting that as well. And we're hoping that he improves. And a substantial number of people do get better. And that's what I said to the kids, is that we are really hoping that he improves and gets better, and that it is reasonable to hope for that.
Yeah.
And they were so relieved. They were in tears.
Yeah. Oh, I can only imagine. I mean, it makes me just want to say to the whole world, I want to play this piece right here, what you just walked through, literally on national television over and over again. Like, this is why you need to have a palliative care consult, because that's a conversation, that's peace, no matter what happens, that you just brought to that family, that they wouldn't have. And I think that's such an extraordinary gift. It's also a reminder of how much we want to be having these conversations before we have to have them, which is something you and I worked toward for years and years, literally years and years. Can you share a little bit about, you gave me an example, at Mount Sinai, for example, there is another number for family members whose loved one has stayed at home.
Right.
Because there is increasingly this feeling across some individuals, I don't want to go. We talked about this last week. Can you talk about what those options, what are you doing? What does palliative care look like right now for those families?
So what's interesting is that when we do ask people what they would want should they get very sick from them, they don't all say the same thing. Yeah. Surprise, some people really want to go to the hospital, like the patient that I was talking about a minute ago, want every shot at life prolongation. Some people really have, they may they've been in a hospital before and they want no part of it, or they are aware that the consequences of being very, very sick in a hospital would lead them to a quality of life that they did not want, and that they felt safer and more secure and more in control if they remained at home and tried to ride this out at home. And we are able to truthfully say that I have a number of colleagues and patients who are in their 70s and 80s who have ridden this out at home. They had it and they got through it at home. So we can't say that if you're over a certain age, you must go to the hospital, otherwise disaster occurs. That is not the case. So some people make the choice to take their chances in the hospital, and other people make the choice to take their chances at home. But we have certain obligations. If someone says, I'm going to take my chances at home, it's not like we're abandoning them. What does the healthcare system owe to people who decide to ride this out at home and shelter in place? And we owe them two things. Well, at least two things. One of them is that we have to make sure that should they develop symptom distress or suffering, shortness of breath, for example, that there are medications in the house that will relieve that immediately. This is not something that you can stay home with. We have to honor that wish to stay home and make it possible to stay home by putting the meds in the refrigerator. And those are called comfort packs, and they contain medications that relieve shortness of breath and anxiety and other symptoms. And they just sit in the fridge, and hopefully they will never be necessary, but they're there as an insurance policy. But the second issue is that many of these people have family caregivers with them at home. And how do those family caregivers get through this, both in terms of reducing risk to themselves of getting sick, because it will help no one if they're both sick, and how do we support them to basically be providing medical support, even though they're not nurses or doctors. And what that requires is 24/7 access to a health professional who can walk them through it. Here's what you do if she starts developing shortness of breath. Take out the comfort pack, open this bottle, use the syringe, draw it up to this number on the syringe. Show it to me on your phone or on your tablet so I can see it. Put it in their cheek. I'm going to sit here on the phone with you and we'll both wait together to see if it works.
Yeah.
You see how that makes it possible?
Yeah. It's so funny that you say that. I spent some time yesterday with Jen Olson. She's the executive director of the Rosalind Carter Institute for Caregiving. So her obsession and Mrs. Carter's obsession is really supporting the family caregiver, which is who you just described. And Rosalind Carter, former First Lady, is known, I guess we call her still a First Lady, is known for one of the most famous quotes in the family caregiver space, which is, there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So Jen, who you can think of as Mrs. Carter's wing woman in this mission, this effort, she's rock star. She actually lives right by the Carters, and they live 2.5 hours outside of Atlanta in a place called Plains, Georgia, which has a population of 700. Plains is 45 minutes from Albany, Georgia, which has been in the news a lot lately for a really hard reason. It's in the county that has the highest COVID-related deaths per capita in the US. And we were talking yesterday about the massive differences in resources that are available in rural communities versus, as they're referred to in Plains, big cities. And Jen is always reminding me, and it's not just big city versus rural. Within rural, there's massive, massive, massive differences. If I don't live in New York and I want some of these options that you just walked through, what do I do?
So the good news is that in virtually every community in the United States, there are hospices. And hospices exist to take care of people who are clearly dying, predictably dying. But that said, they have the skill set to provide symptom relief and support, because that's what people who are dying and their families need. So many hospices are now delivering palliative care to people who are not dying and whom we hope will not die. And especially under these crisis conditions, many of them are also providing care through telemedicine, because the government finally made that okay under these crisis circumstances. So I would reach out to your local hospice or hospices, and there's a listing of them on nhpco.org.
nhpco.org.
Yeah, nhpco.org. And you can Google hospice near me.
Or go to getpalliativecare.org, because people over.
Right. And say, here's our situation. My mother is insisting on staying home if she gets sick. She has some mild symptoms. She's developing fatigue and muscle aches. I'm going to take care of her here. We've made a decision to stay at home, but we need to be able to have comfort pack, and we need to be able to reach somebody at any time if we need help. And what hospices are doing is accepting those patients into hospice, even though they don't fit the traditional criteria of, end-stage dementia or end-stage cancer or end-stage heart failure. They've got an acute life-threatening illness that they may survive, and we hope they will. But they need help during that several week-long period. And so that is what many hospices are doing, and I hope more will be doing, because their expertise and their capability and the access to hospice is so good across the country.
It's such a natural extension.
Right.
So one of the other things we talked about, Jen and I, is how she thinks about her passion for supporting Mrs. Carter and the way that that's transformed how we support the family caregiver and how that's intensified over the last month for her. I asked, how has it? And she said, it's reinforced to me all the ways caregivers are critical to our public health system. Yeah. Caregivers have to do the work of making sure someone takes all their medication so they don't show up at the ER because of their diabetes during this time. And we need those hospital beds for other people. We need caregivers to take care of that person who has a mild COVID experience at home, so they don't need to be in a bed somewhere else. We need to be sure people have their food and their bandages changed so a home care worker doesn't have to go into that house. They're critical in any disaster or tragedy or experience, and this just intensifies that. Can you talk a little about what is the palliative care system, these examples of supporting a family caregiver through these times? Where can I, as a family caregiver, go to learn more about all the things that you just talked through? Is that all on your site?
So there is a public-facing website that we developed that tries to clarify what palliative care is, what it is not, and why, if, say, you have ALS, or say you have dementia, or say you have emphysema, or say you have cancer, it says, read this, Is Palliative Care Right for You? By different diagnoses. We need to put a section for COVID-19 now that I think about it. And I think when you read it, support for the stress and symptoms of a serious illness, support for information sharing so people actually understand what's happening, what to expect, what to do if something worrisome arises. That's the information that people need. With that information and support, it's remarkable what family caregivers and other caregivers can do. They can do just about anything because they have the power of love. And all they need is someone holding their hand to be able to do that.
So one of the things that I was asked yesterday, I had a chance to talk to that group of kick rump women healthcare execs that I spoke to you about last week. And I was bragging a little bit that I got to speak with you again today. And not an attractive trait, and one of these women was commenting how much she appreciated our talking last Sunday. And she said, let me add a PS to this great interview. And my enthusiasm to share with my own kids, I didn't give them the chance to choose the time and place they wanted to have that conversation. Not everyone is as into this subject as we all are. I wish I'd been more sensitive about that. Can you share about the conversation guides you have? Because that's something else you talk about. There is a way to introduce this conversation, and it can be about love, and it is a beautiful conversation as you introduce it in a way that feels safe.
Yeah.
Where is that?
So let me, first of all, attribute the level of sophistication and dissemination of communication skills training to my dear friend Tony Bach and his colleagues James Tulsky and Bob Arnold, who started this organization called Vital Talk, whose mission is to help health professionals learn effective communication and compassionate communication skills. And when this pandemic began, seems like a decade ago, but it was a few weeks ago, Tony and I were talking about that many of our colleagues are going to need to have conversations they've never had to have before, and we need to support them with technical assistance, and that technical assistance is literally scripts that they can read. Because, again, this is an unprecedented crisis and tragedy. Everyone is maximally stressed. Time is of the essence. They don't have time to go to the phone and call someone to coach them through it. They've got to have a pocket card or something on their iPhone that they can just pull up. So, but the skills are the same. So the first thing that you do is introduce yourself and acknowledge the current situation and ask for permission.
Yeah.
Just as your colleague said, she didn't ask her kids for permission to talk about this. The asking for permission serves two purposes. One, it gives people a warning shot that this is going to be a complicated, potentially difficult conversation on topics that are not easy. And it helps people sort of reboot themselves to prepare for that. And the second thing it does is it gives them the opportunity to say, no, not now. I need to take a shower. I need to eat something. I need to go for a walk. I'm not ready for this right now. Let's talk about it in 2 hours. And that is critical, because if you are forcing information on someone not ready to hear it, I promise you they will not hear it. That not only will they not hear it, they will never trust you again. Because they will experience it as an assault rather than a support. So asking permission to begin the conversation is really, really important, and respecting the answer that you get. And then you give another warning shot. I'd like to talk to you about how your loved one is doing right now and what we think is going on. Is that okay? So they say yes, and then you go right to the point. I'm really sorry to say, it looks like your loved one has pneumonia from the COVID-19 virus, and then you stop talking. And that requires training, because I will tell you that as a doctor, you want to keep talking into that. You want to keep saying things to try to make it less harsh or less frightening or less dramatic. But what you need to do is shut up and be quiet so that the person you're speaking to can take it in. and process it. And it feels like forever, but it's, 10 seconds.
And the analogy for that for a family member would be, you have to once you have gotten permission to have this conversation, you need to let those pauses and those silences be there. And
Right.
that's the gift of doing that conversation well, is letting the conversation unfold as slowly as it needs to unfold.
And allow silence. It's so hard for clinicians to allow silence because we want to fix everything.
Yeah.
We so urgently want to fix everything. But in this situation, jumping into the silence with noise just distracts and takes away from the family member or patient's ability to take in what you're saying, process it, and then come up with what they need to know next. And very often they will say, what does this mean for me?
Yeah.
What does this mean for my mother?
Yeah.
And then once they've gotten to that point of being ready to ask you, what should I understand about what this means for us? You can then get into, here's what this means, here's what we will be doing. And then again, having explained that, stop talking.
Yeah.
And allow silence.
So the intensity of what you described that you're going through right now, the example you gave of the beautiful 72-year-old with his children, the role that palliative care is playing right now in this bridge, this incredibly critical, fundamental role of allowing this love to unfold with a family. The mental health of the palliative care workers, how are palliative care workers doing? How are they handling this intense, beautiful role they're playing, but hard role?
It's a really hard role because the suffering is coming at us from three different vantage points. Our colleagues who are suffering, their patients that they're caring for, and we're trying to support them to care for, and their loved ones who are, being kept away from the people they care most about. So there's a great deal of, I would say, extremis everywhere we look. And I would say that because we are a team-based field, so a palliative care team is nurses, social workers, doctors, chaplains, and others, often like physical therapy, occupational therapy, psychologists, psychiatrists, but the core team is those four people I first mentioned, is because the work does focus on some of the most difficult and challenging human experiences that we can have. That team is absolutely essential, not just for high quality care of patients, but to support one another. So almost every palliative care team has regular, for example, conferences where we talk about the feelings engendered by the work that we do. For example, our chaplain has weekly sessions
Right
with
now,
other. Yes, well, now it's daily.
Yeah.
Under normal circumstances, it's weekly. Now it's daily, to help people, the professionals, the palliative care professionals, name their feelings, because very often these feelings are unconscious and overwhelming. But when you have these support, you can name the feeling. When you name the feeling, it has less power over you.
Yeah.
And you can choose how you're going to respond to it. So there's a great deal of professional support resources that have been developed, again, overnight, not only for palliative care professionals, but for all health professionals, because of the recognition of the trauma that is associated with this work.
Yeah. And I always make the analogy over to the family caregiver who's got that same thing going on and needs to find someone that they can talk to. Find another family caregiver and share your stories with each other, support each other. We talk a lot at Archangels about this concept of look, love, lift.
Yeah.
Wherever you are, look around you. There are caregivers everywhere, and they don't necessarily look like what you expect. And take a moment and love on them for what they're doing. Yeah. Recognize that what they are doing is love, and then give them a lift. Yeah. And I listen to you, and I just think, oh my God, put me on your short list of people you call as you're having your own times of feeling so tired. What are lifts that we can do to support clinicians right now? Like, share a couple things that would make a difference for members of your team, for members of the clinical team more broadly.
So the 7 p.m. shouting and drumming and singing and music that was sort of initiated in Italy, I think, that has now come here. New York City erupts at 7 p.m. every night. And that's very meaningful because it helps the doctors and nurses and the med techs and the food delivery and the people who clean the rooms and the people who staff the pharmacy. It's, you know, it takes a village to deliver healthcare. All those people feel seen when that happens. And I think that's really important. For example, every time I go into a grocery store now or a pharmacy, I thank those people for coming to work and for helping their fellow humans get through this. It's the same. And I will tell you, I hear over and over from my colleagues how grateful they are to be thanked by patients and families.
Yeah, this is why and I know we're doing this in collaboration with CAPC, we are encouraging folks to put in their email signature the Archangel's logo and that says, thank you for being a caregiver. And to include in there specifically why they are saying thank you, and to push this out on social media, and to put out posters that say, we're all in this together. Thank you for being a caregiver. Look left. Yeah. What it does is it helps take that 7 p.m. moment that you're feeling and put it everywhere. And it's a reminder of folks to do exactly what you do when you go to the store, when you see your postal worker, anyone who's keeping the trains on the track, all the way from the person who's stocking the shelves to the ER doc to the palliative care team. Thank you is so vital. So 2 last questions for you. One, what can others learn from what you've learned this past week? You're in New York. Others are going to come to their own version of this surge. What words of wisdom can you share for those, because you are in the future for some?
I think the thing that has struck me the most are 2 things. One is the enormous resilience of the human being, and how in a very short period of time, everything we thought we knew is gone. And everything we thought was how we do business is gone. And in a few weeks, we have totally rebooted and redirected what we do to meet the needs of the moment. That's the first thing. It's stunning. And the second is to see the love and commitment and care that people have for one another inside healthcare and outside healthcare, and how not only is that inspiring to see, it is critical to survival. We do not survive in isolation. We are critically dependent on each other. And perhaps we didn't realize that before this pandemic, but boy, you can't miss it now. And if you don't have an adequately functioning healthcare system, people die unnecessarily. If you don't have grocery stores and pharmacies and mail delivery, people cannot live. And so the obviousness of that, which perhaps wasn't conscious the way it should have been before this pandemic, our essential interdependence as a species has really struck me, and I hope strikes everyone in our society. It doesn't matter if you're wealthy. It doesn't protect you. It's better to have lots of money, certainly, but you're just as vulnerable for getting sick as the next guy. And there's something equalizing and humanizing about that reality.
Yeah, there's a beautiful quote, a gentleman named Tim Johnson of Pingree, I'm lucky enough to know, and he said, "Together we are in different boats." And I think that sums it up very well, right? We are all in this together on some level, and to your point, we are also in different boats. And so how this is being experienced by someone who has plenty of resources has some similarities and is also very different in other ways from how it's being experienced from someone who's lost their job. And that's something we are seeing play out. And that's a whole nother conversation that you and I need to have. And I can't wait to have it. I love that you just said, you pointed out the beautiful moments, right? This week has had a lot of hard bits to it, but there've also been these unbelievable, beautiful moments reinforcing how powerful love is. And how much the story you told about the 72-year-old, how much we want to be together and with our loved ones in these times. And I think there is a returning on some level to a recognition of how incredibly important that is. And maybe that is how COVID will translate to societal change. This returning to those fundamental principles. There's a Thomas Rhett song right now called "Be a Light," and aspects that are of it are, I feel, so reflective of what you and your teams do. There's a line they say, in a place that needs country music. I like all music, but this is the time for country music.
Are you going to play it?
I could play it. It says, in a place that needs a change, make a difference. In a time full of noise, just listen. Because life is just a breeze, you better live it. In a place that needs a change, make a difference. And all of the things that you've walked through, I'll send you the song after. You everything you walked through today, who you are, what you're doing, how people are surviving, is in the song so beautifully. And the refrain includes, in a place full of hard times, be a light. And I can't stop thinking about it. And you described all of this light that you've seen. It's Easter weekend. This past week was Passover. It's spring. Where are you finding light right now? What fills you with hope?
Human connection. Just as you said, I regularly call everyone I know who lives alone, many of whom are in their 80s and 70s. And every week I get on a Zoom call with my entire family. There's like 20 of us. And things that I took for granted, I no longer take for granted. I don't take for granted seeing spring come around me. I was too busy to notice in the past. I'm noticing everything. We talk about living in the moment and how difficult that is to do. I feel like I've done that more in the past few weeks, and perhaps since I was an intern. The urgency of everyday life and the present moment has come back.
Yeah. What an extraordinary forcing function for perspective and love.
Yeah.
So thank you. You are such a light for me personally, and I know you are for everyone else who's around you. So thank you for everything you're doing. We send a lot of love to your team, to the teams of palliative care folks across the country. Thank you. Thank you,
Al. You've given me a chance to put in words things that have been unconscious.